Allô? Oui, bonjour.
Salut. Hello, nobody.
Mon ordinateur. يلا صح اوكي.
Good morning, everybody.
Good morning.
Good morning from Cairo.
Good morning. Good morning, Professor.
Yes. I would like to thank you very much for choosing me as a session moderator for this prestigious event. Today is the second day of your first annual worldwide online meeting done through the Association for Scientific Research of the IRIFIV and AISRG group. Today, the moderator with me will be Dr. Xavier Villard from France, and we wish to have a nice and wonderful day, plenty of discussions and interesting topics. I would like to introduce the first speaker, which is a very dear friend of me. I know him more than 20 years ago, Dr. Noureddin Douanjli, who is a very active Vice President General and Executive Director of the Association for Scientific Research and the Reproductive Medicine and Endometriosis Research Group and IRIFIV Center Fertility at Casablanca. Dr. Louange was graduated from medicine at the University of Strasbourg, Department of Clinical Biology, Alsace, and he has the head of Laboratory for Clinical Analysis and Assisted Reproductive Technology, IRIFIV Center Fertility, African Center, Casablanca, Morocco, and is a member of ISRM and ISRG, and he has done a lot of scientific, interesting research, and is founder of the Moroccan Society of Reproductive Medicine and founder of the actual society that invite and against this meeting. Dr. Louange, please start your lecture.
Yes, thank you. Thank you very much. You have finished?
Yes, please.
Thank you very much, Professor Amer, and I hope welcome to all attendees and speakers of this first event of our association.
Your title will be Impact of pH Media.
Yes, exactly. You see my slides?
Yes, very well.
Okay.
Yes.
Problem. Yes, exactly. What problem? Okay. Okay, thank you. Our topics today. One second, please. Enlever les images, ça me dit. Okay. Our topics today is the study of important parameters in embryo culture that influence the results and the quality of our work. It's well known that during in vitro culture, many stress can affect oocyte and embryo competence, especially competence can have devastating effect. We have osmolality, light, toxin, pollutant, mechanical effects, temperature changes, chemical product, pH, it's our topic today, and oxidant if we don't work at the right oxygen tent. The major intracellular processes are highly sensitive to pH changes, including protein synthesis, enzyme activity, oxidative metabolism, mitochondrial function, cytoskeletal regulation, and energy production. In consequences, intracellular pH regulation is a vital aspect of cell homeostasis. We have a lot of cell membrane contain intracellular regulatory mechanism. A lot of exchanger that located in cell membrane of oocyte. It's well known that oocyte cytoplasm has limited buffering capacity to regulate its own pH, and pH intracellular follow the pH medium that has to be well calibrated. It is influenced by protein, amino acid, and other media component. As you see here, there are consequences of pH on the cytoskeleton that regulate position on the cell spindle and chromosome alignment. And also pH contribute to the distribution of the mitochondria, which is correlated of the development competence of the oocyte and embryo. Lowering pH decrease glycolytic activity and increasing pH influence oxidative metabolism. The metabolism is severely affected by the huge changes of pH medium. Swain in 2014 have demonstrated the mean oocyte intracellular pH values at about 7.0 in human. Ovarian oocytes that are growing and have to achieve their fully grow in the ovary lack the ability to regulate pH intracellular and need cumulus cells around to regulate need these cells to regulate to the pH. Granular cells support pH regulation during oocyte growth and maturation. This support is lost with the denudation process for ICSI procedure, and handling for ICSI is processed the day of ICSI. We remove all the cell cumulus from the oocyte, and he is vulnerable to pH changes. And you see here that during early stages of embryo, development, the ability to maintain normal cellular functions such as regulation of intracellular pH, relief of oxidative stress, and ionic homeostasis grow gradually. And the oocyte is very vulnerable, and the blastocyst is present relative resistance to changes. As we know, the pH in the medium level is achieved through a balance between CO2 level of the incubator and the bicarbonate in the medium. It depends on the incubator and the medium types. We reach the target working pH media for oocyte and embryo culture after certain hours. It depends on dish with cover or not of oil of volume and density of this oil, medium droplet, volume, starting pH, type of incubator. At least we expect 8 hours at least to equilibrate the medium for working for IVF. It's the very known the curve to stabilize the pH. It means we have to prepare the lab 1 day before to have optimum condition of pH value for working at the day of ICSI. Factors that could affect pH changes during embryo culture. We have temperature. Embryologists that want maximum accuracy will opt for a pH meter that come with a temperature compensator probe, because all our measures are made at 37 degrees. We need the probe that compensates this temperature. Made caution, be careful, the handling medium have buffered by herpes and MOPS have changes in pH at different temperature. If we have to check this pH before working at 37 condition, and we have an example with 37 condition. The MOPS could lower his pH, and it could be deleterious for the oocyte. The second condition, the production of ammonium, it's a second condition that could change pH during culture. Embryo development, differentiation in culture, embryo endometrium, pH regulation, and gene expression in prolonged culture are affected by modification of pH and production of this ammonium. However, our current product medium now are replaced glutamine by dibeptide form that generate less ammonium, and there are less changes in pH. pH stability depends equally on osmolarity, and we have to use a right oil to overlay the droplet, culture droplet. And the Swain in 2018 demonstrates that the heavy oils stabilize the pH and osmolarity, and it fitted with the new generation and of incubator that we keep embryo for 5 or 6 days. Heavy oil, better stability and osmolarity in pH. We have here manufacturers that produce different density of oils, who can have all density in the commerce, in the market. Embryo metabolism change during early development stages. We have what is the right value. Here, Swain 2002 demonstrate that the better oocyte, the better value for oocyte, it's 735, between 730 and 740. We have the maximum fertilization rate at this pH. And after at the cleavage stage, Karen Miller 2014 demonstrated that between 7.2 and 7.3, we have the high maximum cleavage rate and the maximum quality of embryo at this stage. And the same author demonstrates at 7 for blastocyst stage, we need between 730 and 740, a mean value of 735. This finding doesn't fit with our practice daily, because the new generation of incubator needs a stable condition, one condition for 5 or 6 days. and the embryologist decide for the pH value according to his own experience, 730 or 730, 25 to 27, to not to modify, because we can, the target of this new generation of incubator to make homeostasis stable and not to modify product and incubator, and we have to choose one value of pH during all culture. Here, the value that are recommended by the producer, the firm of the companies, it's in general between 7.2 and 7.4. But every company you have little changes in according to the concentration of bicarbonate between companies. Here, for example, we have the same company and the same medium, but the two lots. If you have one lot works at 7% CO2 and other lot we must have 7.5 for the same target pH, 8.3. We have to check at every new lot. We have to check the pH, even for different company at the same basal buffer. In the right, you see here for HTF basic medium, you have a different pH in function of the company. You have to try to check your pH, even if for the handling medium based EPS or MOPS. Here, equally, it depends. The value of pH depends on the incubator and the media. You have if you work with an incubator, you have a target value of 7.3 for pH. If you change the incubator, you have to recalibrate with the new incubator. It's the value, for example, in this condition with the same value, we need 6 for the first incubator, 5.5 for the same incubator, and we need perhaps 7 for the third incubator for the same pH target. We have to calibrate it according to a new incubator for the same medium. I conclude that the optimal pH use will be according to the media, the incubator, the culture conditions, the lab experience, and embryology goal of each laboratory. It's the embryologist in his lab that decide which value he keep for all condition, culture condition. A few words for measurement. We have classical pH meter. It's abundant now because it consumes a lot of volume and it's quick. It's not quick and not adapted for IRIFIV laboratory. Now we have the probe inside the incubator with lecture on live lecture. We work and you read what happens in the incubator. Our choice is we chose this kind for blood gas analyzer. It need less than 80 microliter auto-calibration once per lot and adapted to culture under oil, result in 5 minutes, and you can check quickly multiple incubator at the same day. We have the use in our lab. It takes less than 30 seconds to have the pH of your working medium. And if you have the value and you can check your incubator, it takes 10 seconds. It's our choice. It's a gas blood analyzer. The accuracy of any pH meter should be validated prior to implementation in clinical IRIFIV laboratory. Thank you. I don't hear you. Professor
Yes, thank you, Dr. Noureddin, for excellent presentation and keeping the time, 15 minutes exactly. I think we would postpone the question until the end.
Okay, no problem. Okay, okay, no problem.
Okay. Our second speaker will be Associate Professor Abdel Fahid Natiq. He is Secretary General of our prestigious association, and he is a researcher and working in the IRIFIV Center Fertility at Rabat, Morocco. He has been graduated from medicine at the University of Mohammed V, Swiss, UMS 5S. He has a PhD in science in genetics, specializing in classical cytogenetics from the Department of Medical Genetics National Institute of Health, Rabat, Morocco. He is a researcher in the IRIFIV scientific group. Dr. Natif is a member of MSERM and IRIFIV. He is founder of the Moroccan Society of Reproductive Medicine and the Moroccan Society of Fertility Conception. Dr. Natif will give us a topic about genetics and of male infertility from karyotype to NGS. Please start, Dr. Abdel Fahi. Dr. Abdel Fahi, you can start sharing.
Je suis en train de partager. Voilà.
Voilà, merci.
Attends.
Maintenant, share your slides. Share screen en vert. Et vous avez votre écran et vous présentez votre diapositive.
Attendez, je fais partager.
Et en bas, partager l'écran.
C'est bon?
On n'a pas la présentation. Share screen en vert.
Oui, c'est ce que j'ai fait. Hein.
Share screen. Et puis, on n'a pas encore votre présentation.
Je trouve un niche.
Tu as ouvert, Hafez, tu as ouvert la présentation derrière.
S'il vous plaît, je partage ça bien. partager ça.
Oh. Toujours difficile, hein?
Ben juste.
La technologie.
C'est bon.
Tu remets d'abord ta caméra.
J'ai ouvert la présentation.
Mais on ne te voit pas, toi.
Vous voyez la présentation?
Non, il faut aller à Share Screen, en bas en vert, et vous appuyez sur Share Screen.
Partager l'écran, c'est écrit en vert, c'est allumé.
Oui, c'est ce que je fais. Hein.
Mais il faut que ta présentation soit ouverte.
C'est ouvert sur la première page. Je ne comprends pas pourquoi.
Et remets ton image parce que tu as arrêté la vidéo. Remets la vidéo.
Attends une seconde à César, parce que là, Et partager l'écran. Voilà.
Là, on ne te voit plus, Hafez.
Voilà.
Voilà, c'est mieux.
C'est bon.
Et remets la vidéo pour qu'on te voit.
D'accord, César.
Très bien.
C'est bon. Vous me voyez?
Parfait.
Parfait. Merci, César. Thank you very much, Professor Amr, for this kind introduction. I would like first to thank IRIFIV-AISRG Association for this great meeting. And I would like also to thank you for introduce genetics for topics in this manifestation. So my talk is about genetics of male infertility from karyotype to NGS. We will see tools of diagnosis and some manifestation of genetics male infertility. Like introduction, we can see that infertility affects more than 70 million couples in the world. Male factors contribute to over than 50% of the cases. And there are great heterogeneity of genetic causes of male infertility, going from chromosome abnormality, Y chromosome microdeletion, gene disease, and more than 100 genes involving in male infertility. There are also epigenetics alteration. For the etiology of male infertility, there are quantitative abnormalities, 70%, subdivided between mechanical and obstructive and alterated production of testicular failure. And for quantitative abnormality, 30% sperm morphological defects or motility. For genetic causes of male infertility, we begin by chromosomal abnormalities, and karyotype is recommended in men with secretory azoospermia or oligoasthenoteratoazoospermia. In couple, if recurrent pregnancy loss, birth of abnormal children, or infertility of a couple, and also in RT assessments. And Sonalia in guideline on sexual and reproductive health 2020, they report that about more than 30% of patients with azoospermia have abnormal karyotype. Now we show the most common chromosomal disorder in men, syndrome of or Klinefelter syndrome, is associated with hypogonadotropic, hypogonadism, and infertility. We can find it in homogeneous or in mosaic. In second hand, balanced chromosomal translocation are the most common structural rearrangements. Here we show translocation between 7 chromosome and 9 chromosome. And the individual affected by such translocation with failure of spermatogenesis because of meiosis impairments can lead to their recurrent pregnancy loss or a child with multiple congenital malformation. Another form of male infertility implicated the chromosome, isodecentric YQ chromosome. Here, a man with azoospermia, 39 years old, and we found a karyotype mosaic with their Y chromosome. It is isodecentric chromosome, and it is a common aberration of Y chromosome. Of most cases we report this abnormality in a mosaic. Another form of chromosomal abnormality involving in male infertility, small supernumerary marker chromosome. This aberration affects on spermatogenesis, and the prevalence of marker chromosome is 3 times higher in patients with infertility than in general population. And here the groups, Thomas Lear groups, eminent cytogenetists in Germany, they report cases, 2 brothers, they have the same abnormality, chromosomal abnormality with marker chromosomic, one fertile and the other is sterile. The other is infertile. Excuse me. They conclude that the position of marker chromosomic in the area of spermatozoa can impact the spermatogenesis going from oligoastenospermia to azoospermia, complete azoospermia. Another form of male infertility, microdeletion of Y chromosomes. This analysis is recommended in men if secretory azoospermia or severe oligospermia, sure after normal karyotype. There are three regions in AZF. There are E, B, and C, and the prognosis factor is XC with microtisy, but AZF E and B is unfavorable, but AZF C is favorable. This abnormality found de novo, and 13% of non-obstructive azoospermia and 6% of severe oligospermia. Here just electrophoresis from our lab to show you the deletion in B and the deletion here in B and C. Okay. Emmett-Aber reports in a famous paper in Andrologia that after undergoing XC treatment, clinical pregnancy and live birth outcome rates with found to be 37% and 25% respectively in groups of infertile male infertile male 1,300 infertile male. Donc, we can see the rates of successful of XC in AZF C. Now is about CFTR gene, genetic of this gene and this disease, cystic fibrosis. About 98% of male affected with cystic fibrosis are infertile, characterized by congenital absence of Vas deferens, and 2% male infertile and 6% obstructive azoospermia. There are a lot of mutation, more than 1,300 in CFTR gene, and the most common mutation in CFTR gene is delta F 580. And the American College of Obstetrician and Gynecologists reports that this analysis or the screening of CFTR for cystic fibrosis can be offered to all patients regardless of ethnicity by a minimum panel of 23 common mutations. For the prognosis, there are excretory azoospermia with normal spermatogenesis. The only option is epidermal sampling coupled with XC, and the genetic counseling is very important here regarding the mode of transmission of this pathology, autosomal recessive disease. Now we can talk about tetrazoospermia with particular phenotype on the spermocytogram. And here we underline the importance of spermocytogram for exploring male infertility. We begin by macrocephalic and multiflagella spermatozoa, or ORCA-C mutation. Pierre Ray in Grenoble and her group were the first to identify this mutation. In 10 infertile men presenting this characteristic phenotype, and in all these men, they identified a common region of homozygosy harboring the Aurora kinase C gene. All the patients who had a typical phenotype with high rates of large-headed spermatozoa were homozygote for this mutation. In our experience in lab, when we have more than 70% of macrocephalic and multiflagella spermatozoa, we find this mutation. Here, I would like to share with you a paper that my colleague Sharqawi Jawad Iman published in 2009 about a consanguinity in Morocco and the effect of consanguinity in Morocco. The consanguinity is more than 15%, and the frequency of heterozygote is 150. And regarding this high prevalence of heterozygote, we don't, in our department, we don't see a lot of requests in this mutation, and we ask, where are the patients? We can dispute this point after. Here, just a pic with two sequence, normal sequence and sequence with deletion in position 144. Look, is normal and deletion represents 86% of this disease. And our colleague Monsef Ben Khalifa published in 2012 a novel mutation in exon 6 that this mutation represents 30%. For the prognosis, as we know, ORCA-C protein involved in chromosome segregation and cell division during meiosis, and the ORCA-C mutation stop of chromosome segregation. Therefore, they give polyploidy spermatozoid, and XC is contraindicated. Another form of malinfertility leading to rounded-headed spermatozoa. It is a rare disease and affects 0.1% of infertile men, characterized by the presence of in the ejaculate of rounded-headed spermatozoa. 4 gene and the most common mutation represents between 60 and 83%, DPY90L2. Spermatozoa have completed their meiosis.
Professor, you exceeded your time. If you can summarize the rest of the
Okay. Just for the prognosis, the only fertility option in this patient is ICSI, and they Nilai reports a successful healthy children in case of total globosospermia. Also in acephalic spermatozoa, donc SEN5 mutation caused this disease in 47%. There are also a novel candidate genes, and the only option also is ICSI. Here I will pass in their last step, new generation sequencing and infertility. There are a lot of papers in this topic. I chose some of them. Here, XU report a familial study of twins with severe astenospermia, and they identify a homozygote mutation in SPAG17. This mutation can be a new pathogenic gene causing of astenospermia. Other group or other center of genetics chose to explore the male infertility with panel gene regarding clinic manifestation and biological manifestation also. There are panel of male infertility, of recurrent pregnancy loss, of ovarian hyperstimulation syndrome. A nice paper published with the Chinese group report that targeted NGS panel sequence could explain only more than 2% by panel 1, 5 gene, and 2% by panel 2, 12 gene of the patient with no obstructive azoospermia after exclusion karyotype abnormality and Y chromosome microdeletion. The author suggests that only a few genes that are directly linked to meiosis can indicate poor microtesy prognosis, such TEX11, TEX14, and CA1. I will finish soon. The last slide. Nanan try to have answer at question, where are you going with gene screening for male infertility? They report and they conclude that karyotype abnormality and Y chromosome deletion and CFTR mutation have been strongly linked to no obstructive azoospermia and severe oligoazoospermia, and CBA-VD obstructive azoospermia respectively. And they conclude currently the NGS technology not for a diagnostic only, but for a research. Finally, we can see that spermocytogram is a key role in genetic exploring of male infertility. Genetic tests in the context of male infertility must be customized, and it is very important to do counseling, genetic counseling before IRT procedure. And thank you for listening, and welcome to Rabat.
Thank you, Dr. Natik, for your excellent and nice presentation that deserves a lot of discussion at the end. I would like to introduce Dr. Ferhat Jenkiz. He is a member of our association and a member of IRIFIV Center Fertility Rabat of Morocco. Ferhat Jenkiz, after graduating from Istanbul University, he has completed his master's degree in histology and embryology at Tarakia University. He is the head of IVF laboratory of Göztepe Medical Park Hospital, a research center in Istanbul, and formerly was the head of the Department of Embryology in different IVF centers. During this time, he showed very interested in sperm morphology, having an ample and multidisciplinary view of round spermatid injection research. Very interesting, Dr. Ferhat. Günaydin Nasil Sinis. Welcome to our meeting. your topic will be temperature monitor and IVF laboratory quality. So the stage is for you. Please, we are waiting for you. Dr. Ferhat Jenkins, do you hear us? I cannot see Dr. Ferhat on the panel. Is he absent?
He doesn't inform us about his absence. I don't understand. But Dr. Xavier, you can present our Professor Amer to replace him for this lecture, not to lose time, I think.
Okay, perfect. Can you hear me now? It's
yes.
okay? Perfect.
Yes, okay.
Okay, it is my pleasure to present Professor Medhat Amer, who is the chairman of the Andrology Department of Cairo University and also the former president of the Andrology Mediterranean Association and of the Egyptian Society of Andrology. He is currently the president of the Egyptian Society of Reproductive Medicine and vice president of the Egyptian Foundation of Reproductive Medicine and Embryology, and chairs since 1995, one of the largest private andrology and ART hospital and satellite clinics in the Middle East, Adam International Hospital. So Professor Amer, there is one thing we have in common. We all studied in Saint-Antoine Hospital in Paris and also at Paris 6 University. So you were in St. Anthony in the urology and andrology department for 3 years in an extra residency program, and you obtained your andrology and diploma for microsurgical techniques at the University of Paris 6, where you were a consultant of andrology. So Professor Amer, please proceed to your presentation.
Thank you, Dr. Xavier, for your nice introduction. I am starting to chair my session, and this topic was selected by Dr. Nuruddin, and I think it's a very interesting topic because many of my patients are asking me if there is any role of medical treatment before non-obstructive azoospermia. But before replying to this question, as you all know, the pituitary gland, FSH and LH, are the direct stimulation from the hypothalamus by G and LH. After that, LH will stimulate interstitial cells of Leydig to produce testosterone, and FSH will enhance spermatogenesis on Sertoli cells. Together with testosterone and FSH, they will act on the Sertoli cells. And inhibin will be secreted to feedback inhibit the FSH secretion, together with testosterone, which will do a feedback inhibition of LH secretion and regulate testosterone production. To do that, we need receptors. So there are receptors on Leydig cells that receive the LH, and receptors on the Sertoli cells that receive the FSH. Both androgen has also a receptor on the nuclei of Sertoli cells. FSH and testosterone are both necessary and act synergistically together to regulate the receptors and enhance the response of Sertoli cell to nourish and enhance spermatogenesis. What we know about empirical medical therapy in non-obstructive azoospermia is that it has no effect, because usually if the level of endogenous gonadotropin is not is usually elevated or normal, and most commonly it is elevated, so testes are under constantly high stimulatory effect. So in non-obstructive azoospermia, the pulse is disrupted in particular regarding to the amplitude of both FSH and LH. So this is a control. As you can see, LH is high, but in non-obstructive azoospermia, the pulse is low. The same happened for FSH. So the optimal stimulation of Leydig and Sertoli cells may not be achieved in a subset of men with non-obstructive azoospermia, and this will lead to lack of adequate intratesticular testosterone level and downregulation of FSH receptors. And intratesticular testosterone is really critical for spermatogenesis and very important for it. And in these patients, usually we have a type, most of the 60% of them or 70% are hypogonadal, with a testosterone level below 300 nanogram per deciliter. And this will reflect the low intratesticular testosterone output caused by reduction in Leydig cell mass or paradoxically weak stimulation of Leydig cell by exogenous LH or both condition. As you know, long ago, we are administering exogenous gonadotropin to restore spermatogenesis in hypogonadism patients. Consequently, hormonal treatment in men with non-obstructive azoospermia has been pursued with the aim of improving spermatogenesis before surgery, despite this patient may display high FSH and LH. And gonadotropin therapy has been explored as a way to optimize and induce spermatogenesis and thus increase success rate in men with non-obstructive azoospermia. The pharmacological principle is to increase intratesticular testosterone, and this can be done by HCG or any other agent like estrogen receptors modulators or aromatase inhibitors. And Shirashi in 2012 published a very interesting paper, and he showed that Leydig cells respond to high dose of HCG stimulation in hypergonadotrophic condition. And this can lead to restoration of free gonadal levels, and he postulated that it may have a positive impact on spermatogenesis and spermatogonia proliferation. And what we know also from the literature, and that sperm retrieval rate in patients with low versus normal testosterone level, that patients with normal testosterone level had a significantly higher chance of sperm successful retrieval. And this is to show you that all the studies are indicating that normal testosterone is a good thing and good prognostic element in these patients. So all these data together suggest that hormonal treatment may be justified in patients with hypogonadism, with low testosterone. And it has been tested by many authors. I will show you later. So medications that boost testosterone production, especially if you use HCG, can lead to a drop on FSH and LH. And we think that this will resend endogenous FSH to normal levels and might increase the expression of previously downregulated FSH receptors. As a consequence, administration of exogenous FSH may help in restoring Sertoli function in patients who has a reduced level of FSH under HCG therapy. However, it has been demonstrated by other teams that desensitization of Sertoli cell does not occur. But hormonal responsiveness during FSH treatment is preserved thanks to FSH receptor recycling. So in consequence, it may be hypothesized that at least there is a subset of non-obstructive azoospermia, those with subnormal testosterone level, in this patient, exogenous gonadotropin, HMG and HCG, or selective estrogen receptor modulators can be tried. Actually, this is an interesting paper that I invite you to read if you are interested in the topic. Kroppi and Kolpi published in January this year, and he summarized the 9 papers that explored the utility of medical treatment before TC. 5 of them in patients that didn't have TC before, and 4 after micro-TC. We have 2 publications in this series of articles. What you will notice that more of the series, each one has its special protocol of treatment, dosage, and regimen and patient selection. So they are not uniform. I will concentrate on the first two, and this is the earlier one, Eidos et al. In Turkey in 2003. He used FSH 3 times per week in patients with FSH below 8 million international unit, and the patient who exhibited high sperm retrieval were those with focal spermatogenesis arrest and hypospermatogenesis. Maturation arrest didn't benefit, and Sertoli cell didn't benefit from this intervention. However, sperm retrieval was high in the treated group, 64% versus 33% in the untreated group. Second old paper in 2003 by Hussein, and he worked on maturation arrest and hypospermatogenesis, and he has striking results. 64% has sperm in the ejaculate. So this paper stimulated the team of Professor Schlegel, and he has done a study on 600 patients, 348 patients, and the other as control. He found that testosterone level didn't differ between patients with positive retrieval and non-retrieval, and he found that in treated patients, 51% had sperm retrieval, while in untreated, 61% untreated. The team of Hussein completed their work and reached 600 patients, and they found that sperm recovery rate was 57 in the treated group, the same as Schlegel in treated and untreated, but in untreated group, in their group, they were 33%. So they use that same treatment, and they have equivocal results. Very strange that they didn't reach the same conclusion. The interesting paper of Shirashi in 2012, he worked on hypergonadotrophic patients, like not the other patient, normogonadotrophic one, and using HCG large doses, he was able to take a drop in FSH, and FSH was taken in 13 patients, and after that he used FSH to patients where there was a drop. Interesting, 6 patients had the sperm retrieval in the patient group, which is about 21%, but 4 of them were in the hypospermatogenesis group. For me, the hypospermatogenesis from our database, if you do a second trial, you have at least 92% of patients that will have sperm. So I don't think that hypospermatogenesis is a group on which we have to focus our researches. This is a paper that we have done also going in the way of downregulation, and we did it with testosterone injections, and then the patient took FSH, and we found two of the 20 patients with positive sperm retrieval, which is equal 10%, but this was not statistical difference with our control group. So you cannot take our study or the study of Shirashi because these numbers are really low. You need more numbers and a big series to know what is going on if you use this protocol. I think that our paper published in 2019 is the largest series in the world up to date, done on 1,400 patients. And we used various protocols, all combinations that you can imagine, and we didn't prove any significant results between treated and untreated patients. So people may say, why don't you give enhanced testosterone production anyway? Actually, there is lack of effectiveness, strong evidence. As you see, it's a debatable issue. Also, it may be waste valuable female reproductive time. If the lady is old enough, you cannot spend time on doing things you are not sure about it. Also, it is a waste of resources, but because this type of treatment are expensive, and also it is a potential of harm. Yes, if you give wrong high dose, you may have opposite effects. You may suppress FSH if ECG is used alone and you don't use FSH with it. Also, if you exceed certain level in testosterone, you may have an increase of risk of thromboembolic events in ischemic sequelae. You increase hemoglobin and hematocrit levels. And it's a well-known fact in erythrocytosis following testosterone therapy. Also, there was a side effect reported, excessive unilateral profilation of spermatogonia in a patient with non-obstructive azoospermia after clomiphene treatment in such a patient. So to conclude, as you see, there are no randomized controlled study has been examining the role of medical therapy versus no treatment and didn't compare drug regimens. And a definite conclusion regarding sperm production after enhancement of endogenous testosterone cannot be drawn due to the lack of well-designed clinical trials. Although the rationale of such approach is theoretically sound, studies in the field have provided conflicting results so that the benefit effect of hormonal optimization is yet to be demonstrated. Overall, limited evidence suggests and justifies that hormonal medical therapy might increase sperm recovery rate and allow the return of sperm in some patients with hypogonadism. But on the other hand, the availability is also promising, is insufficient to recommend hormonal therapy as a standard clinical practice to improve sperm retrieval for every patient with non-obstructive azoospermia before surgery. Therefore, the final conclusion, it was stated by AUA and IRIFIV in their guideline in diagnosis and management published this year, that patients with non-obstructive azoospermia should be informed that limited data supporting the pharmacological intervention prior to surgical intervention, and this was a conditional recommendation that it can change at any time with new evidence, and the evidence was the lowest one was the grade C level. So thank you for giving me the chance to speak about this topic. So I think that I have to introduce our next speaker, Dr. Pierre van der Zwijman. Pierre, are you with us today?
Yes, I am present. Yes. Hello.
Hello, Pierre. I'm very happy that you are with us today. Pierre van der Zwijman is a dear friend from long time ago. I know him since long time. He's also a friend of our association Egypt EFRI. Dr. Pierre is a member of Belgian Society of Reproductive Medicine, a well-known figure in our field, and he has been a permanent external partner of IACANTRO since 1992, and he is the biologist who achieved the world's first pregnancy using testicular sperm. Yes, he's the one. And since 2004, he has imposed a closed vitrification method for oocytes and embryo closed vitrification that we know today, and it makes it easy for the average biologist to apply and comply with the EU directives. He is a strong member in the ESHRI and in the cryopreservation of human gametes, and he has a lot of publication. So welcome, Dr. van der Zwijman. Your topic today will be osmotic stress associated with vitrification of oocytes, a very interesting topic. So the stage is yours, Dr. van der Zwijman.
Thank you, Professor Amer, for this introduction. I will start to share my slides. Okay, you get them? You can see them? Yes?
Yes, excellent.
Excellent. Wait, I will try to close my share. Okay, perfect. Okay, thank you for the organization committee to invite me and to present you some data on the topic of oocyte vitrification. So, which stresses do the oocyte have to endure during a vitrification process? And I will try to give you some suggestions to reduce oocyte stress during a vitrification process. So if we look back, I would say more than 15 years ago, there was we could read plenty of publication on application of vitrification for oocyte donation for different reasons. And one of the main reasons was creation of an oocyte banking. That means they had to handle oocytes from young patients. And the literature showed that vitrification was superior to slow freezing. We need less oocytes to obtain a baby. And there was no difference with fresh oocytes for different parameters. So everyone at that time was happy, and vitrification I would say, was considered as the best method for cryopreservation of oocytes. And vitrification is defined as a process by which the disordered liquid state of solute is brought to a standstill and as a solid without crystallization during cooling. And the strategy to reduce the likelihood of lethal ice crystal formation is to expose to the biological material to high concentration of permeable cryoprotectant and to achieve fast cooling and warming. And I would say fast cooling as well with open device and as well with closed device. But the situation was totally different as when we had to manage afterwards oocyte from advanced maternal age. And we observed a drop in the results. And this is a nice study for the team of Ubaldi and Lorenzi, who compare the clinical outcome between fresh cycle and warm cycle. And what we observe, first of all, with fresh cycle, and this is normal due to the unemployment rate, that the ongoing pregnancy decrease with the increasing of the age of the patient. But when we analyze the group of the vitrified oocyte, we observed a drop, but the drop between fresh and vitrified oocyte was dramatically decreased from 22, for example, to 7%. That means that this reflects the fragility of oocytes for advanced maternal age, which have to cope with non-physiological conditions. And we have also observed this in a study comparing fresh oocyte and to vitrified in an oocyte donation group. What we have observed, even though quite good survival rate, we have observed a drop, a significant drop in the rate of top quality blastocysts in the fresh vitrified oocyte as compared to the fresh group. Also, in our center in Belgium, we observed also a drop of 44% of top quality blastocysts in the vitrified oocyte group. So the question is, which stress is induced by the vitrification technique? And if we analyze the different steps, we have different steps in the vitrification process, the exposure to high concentration of cryoprotectant, and we go to 5 to 6 molar. And that means more than 5,000 to 6,000 milliosmol. Then we plunge in liquid nitrogen, the storage, the warming, and the dilution of the cryoprotectant. And each step finally induces kind of stress to these oocytes. So the oocyte have to tolerate and adapt to this non-physiological condition that may induce permanent and lethal damages. And today we will focalize on this osmotic stress that we induce during the exposure to cryoprotectant. And this is an oocyte, and this oocyte is specialized specific orema with low permeability to cryoprotectant, low surface to volume, a complex structure. And in fact, we have the membrane of the oocyte. The membrane of the oocyte contains aquaporine, and aquaporine are very important. This aquaporine are specific protein channel that permit the osmotic flow through the membrane. And that means that it controls the transport of water and cryoprotectant out and inside the oocyte. That means that translocation of aquaporine to the cell membrane plays a crucial role to keep and maintain continuously the osmotic pressure balance in this oocyte. That means that these aquaporine that are included in the membrane is a kind of dynamic control. So, and we have also next to this orema, the plasma, the metaphase plate, we have the organelle inside the oocyte and also the cytoskeleton. So all these parts of this oocyte are very important. And you can see oocyte in a physiological condition and oocyte in hyperosmotic situation. That means that during the hyperosmotic reaction, during the exposure to hyperosmotic situation, the oocyte swell and also shrink. So which part is impaired in this oocyte? And there was a nice study from Hosseini, we have shown that the cytoplasm is more affected by vitrification as compared to the metaphase plate. And his conclusion was that osmotic and thermal stresses induce cytoplasmic insufficiencies. And this is the main cause for poor competence of vitrified oocytes, which in turn highlight the crucial role of mammalian ooplasm to support resumption of meiosis, fertilization, and embryonic development. So these external stresses may compromise the intracellular spatial orientation, functions, and distribution of the organelle, and may disrupt the microtubular and microfilament networks. So, and we can see here what the different events that occur during the fertilization process. I will not go to detail, but you know this very, very well. So, are there some, I would say, suggestions to reduce this mechanical and chemical osmotic stress? First of all, some advice oocyte activation. I will not enter in details here. We can reduce this intracellular cryoprotectant concentration, and we are still working on this at the present. But also we can control the addition of the cryoprotectant in a more and smooth way. So this is a graph that shows you how cell react to hypertonic cryoprotectant solution, and we can observe that first of all we observed a shrinkage of the cell due to the outflow of water, and after that we observe a swelling of the cell according due to the entrance of cryoprotectant together with a small amount of water. So during these steps, chemical stress may be induced, but also mechanical stress due to this swelling and shrinkage process. And when we perform oocyte vitrification, you know very well there are different ways to add the cryoprotectant by merging the drops, by adding the cryoprotectant in small, continuously. And here is a way how we add the cryoprotectant, or method we add the cryoprotectant in 5 steps. But then our idea was why not to reduce finally this osmotic stress by increasing the number of steps, but during the same time. And what we have done, we compare finally, this is the volume change of a cell during exposure to different cryoprotectant solution, increasing the cryoprotectant solution, and you can observe the increasing the shrinkage process and the swelling process for each solutions. And we observe this during this cinematographic analysis, and we have compared this to a smooth addition of the cryoprotectant. That means we reduce the concentration for each steps, but what we observed a kind of smooth addition. We have done this first for germinal vesicle oocytes, and we compare the 5 steps to the 9 steps. And what we have observed, first of all, the survival rate, because you know that vesicle germinal are very sensitive cells. We increase the rate of survival, 61 to 87%, but also we increase also the rate of resumption of this germinal vesicle oocyte to the metaphase 2 oocyte from 64 to 73%. We have started to do this on metaphase 2 oocytes, and what we have observed, the same survival rate, 5 to 9 steps, but the rate of top quality blastocyst was 2-fold higher after adding the cryoprotectant in 9 steps. So multiplying exposure to 5 to 9 steps with a constant addition of cryoprotectant reduce osmotic shock, significantly increase the survival rate, and increase the number of metaphase 2. And I think that in the future, now there is a trend to try to adjust the cryoprotectant to the oocyte by using microfluidic platform. Then the last suggestion is to give time to time. That means that there are several studies in the animal that have shown that oocyte need an extra time to restore the damage to the cryopreservation procedure. And in fact, if we look, this was our first way of vitrification of oocyte and performing the warming. That means that after the warming, we perform, I would say, the ICSI between 30 minutes to 2 hours. But then, according to the literature, we think that it may be better to restore the cytoskeleton by giving more time to the oocyte to restore the cytoskeleton after the warming. And we increase the time after warming to 3 or 30 to 4 hours. And what we observed using this process, we observed also an increasing in the blastocyst rate and the top blastocyst rate by giving more time to the cytoskeleton, to the organelle, to resume their initial architecture. So my last slide to conclude, the permeability of the plasma membrane to water and cryoprotectant is important for the tolerance of cells to osmotic stress and is crucial for cell survival during cryopreservation. Non-control osmotic pressures induces lethal mechanical stress or chemical stresses. This will affect dramatically the aquaporin translocation to the cytoplasmic membrane, impairing the outflow and inflow mechanism. That means I didn't show the slides concerning this topic, but there are quite a lot of articles showing that if you disturb the aquaporin translocation, that means that you impair the osmotic exchange. So smooth addition of cryoprotectants is one option to reduce the osmotic stress. Give time to time after warming to restore the full architecture of the cytoskeleton is also beneficial. Thank you very much for your attention. Thank you.
Thank you, Dr. van der Zwijnen, for this excellent work that you shared with us today. If you have time, please stay with us because we will have some questions by the end of the session.
Okay. Yes.
Thank you. Thank you very much. I have a very interesting information. Dr. Ferhat is with us. He's going to share his presentation now. I'm not going to introduce him again, but because I introduced him before. So, günaydın, Dr. Ferhat Cengiz. Günaydın.
Günaydın.
Nasılsınız?
Çok teşekkürler. Nasılsınız?
So the stage is yours now. You are going to speak and tell us temperature monitor and IVF laboratory quality. So if you would like, you can start sharing your screen now.
But I can't share my.
You'll be able now. You'll be able now.
Yes.
And if we can, after sharing your screen, we would like to see you also, if it's possible.
Okay.
You are with us from Istanbul today?
No, I am a different part of Turkey now.
Okay.
Sorry.
So you go to share screen. Share screen.
Yes, do you see?
No, we don't see. But you have to push on the bottom green button, share screen, and you will have your screen, and you will select your presentation. So you go to share screen, on green, down your screen, you open it, and you have your computer screen. You select your presentation.
Now is it okay?
No, we didn't see your presentation. You have to push on your presentation.
I think it's now, it will be okay. Now?
Yes. Just make it full screen, yes.
Okay, do you hear me?
Yes, we hear you. But we don't see you. Now let us see you.
Okay. May I start?
Yes, but if we can see your face, it will be great.
Okay.
So I unmute the video.
Okay. Wait, please. Yes. And
yes, yes, it's good. We can see you. Please start your talk, please.
No, wait. I think it's okay.
Great, great.
So sorry before for technical problem. So sorry. First of all, thank you a lot of for your organization committee, my friend Nurettin and Mustafa Zakaria. And my name is Ferhat Cengiz. I'm from Turkey. I work for Memorial Digital Hospital. I am a senior embryologist. I want to talk this today about temperature control and IVF quality control in laboratory. I will try summarize for you because we have a little time, and I will talk about control, medical laboratory standard, and quality control equipment and standard laboratory facilities and human rescue and personnel. And last one is take-home message about quality control. What is the quality control? What's the control? In the last year, in the last 40 years in IVF, IVF has changed infertility treatment and at the same time become more complex and adoption highly technological laboratory procedure and including freezing oocyte embryos, and therefore it's very important laboratories apply and maintain and highest quality standards. Quality can be difficult concept understand the often as beholder. In IVF laboratory, often defined by success rate of the clinical result inceptions, determine of stability of IVF laboratory change. For the application of a system in which all personnel know what, how, in she, and how often they do it. Quality that is part of high quality laboratory often overlooked. Now I talk about factor affecting a success ART laboratory. We have a lot of factor affecting success of ART, diagnosis and therapeutic guidance, ovarian stimulation, ovarian oocyte retrieval OPO, IVF procedure, embryo transfer, luteal phase support, treatment. Condition in success in the IVF laboratory, the basic condition success IVF centers from equation of gametes of embryo transfer, medical equipment, sterile space, and very careful and periodic models of quality control F standardization. Why we need quality control? Rakowski and their friends presentation in World IVF Reproductive Congress. They said laboratory improvements directly affect the result of ART programs, and program results are mostly influenced by laboratory variations. So why quality management? because we need stabilize high performance in all process and minimizing possible errors and to ensure continuous development. Now I talk about quality guidelines and if we want we count them as MSERM, IRIFIV, colleague of American Pathology, Association of Clinical Embryologists. You now see some publication about quality control in IVF laboratory. And the last one, quality and risk management in the IVF laboratory 2015 by writing Sharon and David Mortimer. It is best book about quality management for the IVF laboratories. Calibration 5 for quality management system ISO 9001 for medical laboratory standards, and for all ART laboratories we need 15,189. Our third topic, human resources and personals. It's a very important point for me. If staff management, we have some main titles, which are experience must be enough, writing notification and duties, responsibility and each staff. Now I want to talk about interesting point, which is controversial between employers and employees during years. Although there is research about this issue for the German Society of Human Reproductive Biology and ICRM, it determined as the number of staff has to be adjusted according to number and nature of procedure performing in the laboratory. You see for how many cycles for the year, how many we need a person in work in the laboratory. This is for German society, and this is for ACRM said. Training, the planning of IVF laboratory staff, responsible and senior embryologists should be undergo continuous training program. And the authority and performance responsibilities and actions may be granted and person after they have defined training have demonstrate that they are educated. Measured of performance of the team members, how to be performance measured. In the short time, oocyte maturation, embryo quality assessment, and evaluation of sperm parameter. In the long time, per transfer and how many pregnancy, and for fertilization and generation rate after ICSI application. Now you see graphics show different IVF personnel in laboratory, pregnancy rate after transfer. You see 50 personnel is a very low performance showed us. training of new employees is laboratory, how many our new colleagues, theoretical learning and techniques, and application under control, examination result of application period without control, then starting application and permission and teach the new embryologist. Our next topic about standardization of laboratory facility and procedure. Quality control in origin result, fertilization rate, by checking embryo quality, pregnancy rate, multiple pregnancy rate, and implantation rate. This slide about ESRG. We have many factors affecting pregnancy outcome in IVF laboratory. We summarize some used disposable material, aspiration needle, pipettes, glass material, heat blocks, andrology laboratory incubators, about embryologists, gynecologists, andrologists, nurse, and clinic lady is very important in IVF laboratory. After those all process, now we can define reproductivity. I want to talk about this point. Reproductivity is the effect of contact material on the gamete and embryology, its functions. We understand reproductivity with low implantation rate and decreasing pregnancy rate. And if we explain quality control test methods for reproductivity, these are mouse embryo test, sperm survivor test, and hamster motility test, somatic cell culture, and other. We checked and confirmed this test. This is most known quality test, mouse embryo test. Its safety and efficiency, the culture made and disposable are determined, and observing in vitro development, mouse embryo exposed in item to be tested. Blastocyst formation and cell number should be above acceptance criteria. It might be upper 80%. And the second famous one test is sperm survival test. Sperm survival test, motility of spermatozoa test sample compared with control sample after 96 hours, percentage of motility sperm control. It must be under 0.85. It will be toxic. It's one research about sperm survival test, test made by Nice and all France, 2009, 36 products types, 72 different brands were tested in 350 human survival tests, and the research is very interesting. About 35% is where how can reproductivity be reduced? What can we do about it? There is some methods we have, like develop our laboratory test and sperm survival test, except and disposable materials washable, and use of mouse embryo test material always when available, and culture and handling media and disposable. If we change, we can reduce reproductivity. Now, it's very important about for embryologists is quality control of laboratory equipment. We have a lot of equipment in IVF laboratory, like incubator, CO2 tubes, flow control, and control of clinic microscope, manipulator, pH meter, osmometer, heated working surveys, liquid nitrogen tanks, and etc. etc. And checked hint indicate morning temperature thermometer, daily and evening CO2 indicators we checked in the incubator morning and evening. It's also measured with the pump 3 times a week. Incubator waters change once a week, and everyday humidity control and microbiological control every 6 months, and measured weekly and when in laboratory new incoming media. And after by biomedical department or maybe company, it's maintenance and calibration 3 times a year, and gas and heat parameters should be observed at 48 hours, and filter change is changed every 3 months. Now, in different study France, that different CO2 levels change implantation rate and implantation rates day 18 and fetal development rates per embryo for 5% we see 68 for 6% we see 82% is very different, and change for pregnancy.
Dr. Jenkins, please, we are running out of the time. If you can summarize the remaining of your
okay.
1 minute.
Okay, it's very okay. Laminar flow we clean and 6 months. You know, our microscope is very important. We clean every day, and the daily cleaning we twice a year. Liquid nitrogen we all check twice a week. Refrigerator and freezer, we know 2+ and 6+, and freezer mains 18 and mains 26. We know control media, you see certificate, and we check every time CE, ISO, and tissue culture tested, and pH control is every time we need. And take home message I want to tell. IVF application is secure quality control system to be patient-based. Standardization practices should be initiated. IVF treatment, single embryo transfer to be applied, establishing standards of cases should be standardized. All personnel should be aimed to complete laboratory practice and treatment infertility. We need for training, monitoring of the individual staff members. Selection of culture condition, individual laboratory culture strategy are complex and highly varied, and data which base the selection of specific culture strategy. And the end, we must know how to monitor, calibrate, and osmometer, handling of storage of consumables, and including we need control of inventory. We need discuss the importance and quality control and management. Our aim should be to increase the number of take-home babies. And I want to thank you, all participants, organizing commission, IRIFIV, and my IVF team. And thank you so much, my dear friend.
Teşekkür ederim.
Önemli değil. Çok sağ olun.
Teşekkür ederim Dr. Ferhat for this excellent presentation. I'm wondering if Dr. Ma'moon Banat is with us. Dr. Ma'moon, can you show yourself if you are already on the stage? I cannot see Dr. Ma'moon.
So I'm starting recording now. Hopefully it's gonna work. I've been trying this for 3 hours, I would say. So, yeah.
Welcome.
Okay. Hi everyone. My name is Ma'moon Banat. I'm a senior embryologist. I'm working at Olive Fertility Center in Canada, and I am right now in Jordan for a short visit, and I've been invited by my friend and colleague Banatel to present a topic at one of the Q&A sessions with the Jordanian Society for Fertility and Genetics. It was a very nice experience. I was very happy to meet lots of colleagues and friends, and thank you, Dr. Khadan Khamis, as well for having us yesterday. So if you don't know Jordan, for those who are watching this video, once you arrive Jordan, you have to try the shawarma Arabi. Since I have arrived 2 weeks ago, I had already 6 shawarma Arabi. It's very tasty and it's very nice. And I'm leaving next week. And I may take another one shawarma Arabi before leaving. So yeah, let's start the topic. So the topic is, should we go to day 7? And when we're saying to day 7, are we talking about like embryo transfer, freezing, or biopsy? All these answers, all these questions will be answered by the end of this very short presentation. In the beginning, like, not everyone likes to change. Changing is something that people want to avoid. They don't want to change because everybody will be happy with what they have learned and what they are practicing, and changing always is something that needs challenge, I would say. So if you're happy with your results, why to change? Just stay with whatever you are doing. But if you move to a different place or different country or different city, you might be forced to change because maybe the lab director has another vision. Maybe the city or the country has like another regulation or rules that you have to follow. So I have shortlisted here some like main points that why people need to change. The first thing, maybe the experience. So like personal experience and maybe what you have studied, what you have did during the research, the work, and so if you gain more experience, you think you should do something new. And sometimes you have to change your practice if you are working with different cultures. Like some cultures, the people, they are educated, they would be like on a level of awareness that they would know maybe the complications of twins, where other countries or other cultures would be happy if they had like twins or triplets after IVF trial. And from here, we could say why people would be happy after having like this, like news, like saying that you have triplet or twins, even though that there are complications because the economical situation would play a role in that, and the social stress as well, like from the family, friends. So and some countries would cover these expenses, while others they would suffer to get this money to cover their IVF trial. As well, sometimes your practice will be different if the timing is a factor, like if your patient will be traveling very soon, or if she's getting old, or if she is going through some chemotherapy or having some like medical history. So your practices will be different. As well, as I've said before, the regulation and the rules of the country or the city. Like sometimes within the same country in different cities, you would have like different like regulation authorities like that will allow you or will not allow you to do some techniques like embryo freezing or embryo biopsy for genetic testing or for sex selection, egg freezing, sperm freezing. All these things will go under this will go under the authority and the regulation, and if they will not allow you, so you have to change your practice. Well, other countries, they would say you can't culture embryos beyond like day 1. So once you see the 2 p.m., you have to freeze the embryos and just keep 2 for culturing and do the transfer. So, and all these even regulation and laws are changing with time. And as well, the workload, like if you're working in a very busy place, your practice will be different. If you're working in like a place where we're doing maybe 1 or 2 cycles per day. So again, if you gain more experience, if you gain like more, if you are exposed to new techniques or new literature or new research, new findings, sometimes you have maybe to try to change. And examples of like these things is IVF versus XA, freeze all versus fresh embryo transfer, day 3 embryo transfer versus day 5 embryo transfers. And here I'm not going to discuss like which is better, like day 3 or day 5. It's not my topic. But we all know that like the implantation happen or take place on day 5. And for those who are not doing embryo transfer on day 5, they might be pushing some cases from their cycles to go for day 5. But there's some certain criteria, like if they have a good number of embryos, let's say 7 or more, and they were like good grading, at least 4 grade 1, and if the case is going to be biopsied for PGTA or BGD, and then they're going to do the biopsy on day 3, and the results will come up, and they will do the embryo transfer on day 5. And I'm not here as well to discuss which is better to do embryo biopsy on day 3 or day 5. And sometimes it's upon the patient preference. If he would say, or they would say, I want to transfer my embryos on day 3, or I want to transfer my embryos on day 5. So we all know that the implantation takes place, as I said, on day 5. And I will just try to turn on my pointer. I don't know if it's going to work. It should be working. Yes. So yeah, the implantation starts here. I would say it's going to start invading the uterus cavity on day 5 after the embryo will be hatched and going out of the zona and start invading the uterus. And the implantation would take like another 4 days to 5 days, I would say, to be fully implanted in the uterus cavity. And like IVF has too many controversial, like we all knew that before compaction, the embryo would need less glucose, high in pyruvate and high lactate, and after compaction, the embryo will need high glucose and lower pyruvate and lower lactate, as well as other amino acids, essential and non-essential amino acids. But still, we find out now we have a single single-step media, culture media, where you put the embryo and just leave it from day 0 to day 6 without changing on the embryo. Just keep it there, and you can watch the embryo from your time lapse or from your embryoscope and see it like by the camera that you have, and all see all the division, and then choose the embryo for transfer or for biopsy or for freezing. And still, we have the sequential media where you have to change the media on day 3 or day 5 maybe. So the next, okay. So Black's grading. If you're pushing to day 5, so you have to have criteria to choose the best embryo for transfer, for biopsy, or for freezing. And every lab has its own criteria for freezing, for biopsy, and for embryo transfer. And I'm not here to discuss which criteria is the best. So every lab will choose the embryo upon their own experience, I would say, and upon like what they have results in the lab. And again, it's like this day 3. So when you go to day 3 and you want to decide, should I biopsy this embryo or should I not biopsy this embryo, you would see the fragmentation, number of cells, and the division, and you choose the best embryo for embryo transfer or for biopsy or for freezing. The same thing on day 5. If the embryo is not good, even if it was still dividing, still in progress, but you feel it's not fit for the biopsy or for freezing for embryo transfer, you might just leave it for one more day. And this is the routinely practice, I would say. People will leave it to day 6 and see if there is any more changing or any progress, so you can proceed with freezing or biopsy. So there is grading, as in this picture, like Gardner, you would go from early blastocyst to hatched blastocyst, like 1, 2, 3, 4, 5, 6, and this stands for the expansion and the hatching or hatched embryo. And then it's A, B, or C, and that's upon what's the quality of the inner cell mass and the trough of the derm. So sometimes you will see an embryo on a borderline. You can't tell if, shall I freeze it? Shall I just wait? If it was a little bit more expanded, if the endosomal mass was more like cohesive, I would go for freezing for biopsy. So this is, like the lecture saying, what will happen if the embryo was on borderline on day 6? Shall we leave it or it doesn't matter? So let's see. And one more thing, that grading the embryo is subjective. So what I may grade as a 4BB, my colleague could grade it as 4BA. Okay, what I could grade as 5BC, my colleague would grade it as 5CB. So it's subjective, and it's like never would be the same, like between embryologists in the same lab, and it's different from eye to eye, and sometimes you have to move the embryo like under microscope just to make sure what is the good grade. And sometimes the embryo will trick you because it will expand and collapse, and you need to know if it did that, if it did that or not. And we're gonna see some video on that as well in a bit. So sometimes, as we said, some embryos are slow in progress, and the reason behind that we're gonna discuss it in just a few seconds. And it might be the cause of the infertility. So like the embryo, when it reaches to hatch blastocyst and it's ready to be implanted in the uterus, it's already late. It's already not synchronized with the lining of the uterus. So it might be the cause of the infertility. And the plastulation rate in any lab will be affected by how the QC in the lab going on. Like if you have a very strict QC and a good QC, you should have a good plastulation rate in the lab. Like in terms of media, the incubator, and let's just keep the genetic aside. So in the term of media, incubator, and other QC that you are doing in the lab, as well the embryologist, the technician that is working in the lab. And sometimes the plastulation will affect by the genetics. So some studies saying that if the embryo is aneuploidy, that means it's going to be in slow in progress. However, not too many studies support this status. So this review is a very good one, I would say. It's being published in Human Reproduction, and they have collected lots of data. And it's a new one. It's being published in 2018. Not that new, but still, it's good. And they have collected lots of data from different studies. And when we say day 7 culture for embryo, you'd say something, you would think that it's something new. Well, in this study, I was like shocked that the first cultures that started for day 7, it was in 2008. And what they found out that on like day 7 blastocysts have implantation rate between 17 and 56%, and clinical pregnancy rate between 20 and 56%. And the live birth rate for day 7 blastocysts varies between 11 and 42%. And this is like good numbers. And there is limited evidence on whether day 7 blastocysts result in lower pregnancy and live birth rate relative to day 5 and day 6. And there's another like nice finding where they said that the more expanded your blastocyst is, the more higher, and it's the higher live birth rate that you may have. So if you have like 3BB on day 5 and you waited one more day to day 6 and it became a 5BB, what they're saying it's more beneficial and it has a higher live birth rate. However, some other labs will be happy with having 3BB on day 5 and will just go and straight away and freeze it. So again, it's every lab has their own criteria for freezing and biopsy. And again, so why the embryo is slow? According to what they have mentioned in this review, it might be lots of factors, starting with the age or the FSH or a combination of lots of factors. Okay, and some said is the aneuploidy. But again, this evidence, although I would just read it from there. So although there is evidence that aneuploid embryo may progress through blastocyst development at lower rate, this has not been supported by all studies. So it might be, but it's not like 100% thing, because still you may find a normal embryo, euploid embryo, that is slow in progress. And this table from this review is very nice. So you can see here from 2008, and the studies or the data that they have collected till 2017, and this is the number of the embryo that were included, and the percentage of day 7 blastocysts cryopreserved or biopsied out of total number of blastocysts utilized. And you can see it's very low number that will reach to day 7. So you don't expect to see too many embryos like reaching day 7, like having 100% blastocyst in day 7. No, it's not. It's not like, it doesn't work like that. So you should have like good blastocyst rate on day 5 and 6, But if you push embryo to day 7, the percentage that you may have something that is good or fit for freezing or for biopsy would go between 2% to 8% of the total embryos. And again, you can see every study, they had their own criteria, like the minimum criteria for the grading for the embryo for freezing or biopsy. So for this study, they chose 4 BB and more. And there's one 3 cc, and the other one is 5 cc. So it's different. Every lab has its own criteria. And I'm not going to say which one is better than the other. But we can see here the implantation rate following frozen embryo transfer. So the implantation rate is 44, 43, 30, and like 50, 56. So it's like good rate, good percentage. The same thing with clinical pregnancy rate following frozen embryo transfer. And I'll try to move my picture from here. Okay, and live birth rate as well following frozen embryo transfer. So it's always frozen embryo transfer, as you can see, frozen embryo transfer, frozen embryo transfer. So never fresh embryo transfer for day 7 embryos. And the other thing is the average number for embryo that they have transferred range between 1 and 2. So it's almost single embryo transfer. All right. Oops. Okay. I don't know what I did. I'm still training, as I said. Okay. Let's go to that slide, please.
Thank you. Only 1 minute. Excuse me.
Discussions supporting this opinion that embryos will benefit from culturing the embryo 1 more day, especially those embryos that you believe they were not fit on day 6 for freezing biopsy. So you say it's like on a borderline and you don't feel comfortable doing it, just leave it for one more day and see if it changes. So again, this study, I would say, so a patient with slower growing embryos requiring extended culture to day 7 can be comforted in knowing that these embryos can be used for transfer and that successful pregnancy outcome is achievable. So it's, again, and more studies as well were published, like this one in fertility and sterility in 2020. And this one was comparing with a comparison of conversion and aneuploidy rate between related IVF laboratory with different volumes. And they are suggesting that busy IVF labs would benefit or they might be seeing more embryos on day 7 because sometimes the timing and they can't just go with the procedure timing because they're busy. So they would benefit and they might be seeing more blastocysts on day 7 than smaller labs. And more studies as well. So even like frozen eggs, they would benefit from this, leaving embryos for 1 more day. And so what about like day 7 embryo transfer? So if you want to say, what about day 7 embryo transfer? Let's go to day 6 embryo transfer and see what the studies are saying. So this study here saying elective embryo transfers on day 6 reduce implantation compared with transfers on day 5. So they said you just should avoid transferring embryos on day 6. And if it was very difficult, like the patient can't come or something happened, it's better to freeze the embryo and just do frozen embryo transfer for the next cycle and not to transfer the embryo on day 6 of the current cycle. And this was published at Human Reproduction in 2017. So more studies as well for the frozen embryo. What if you did freezing on day 6 and then on the next cycle you wanted to do the frozen embryo transfer? So again, you should avoid transferring the embryos on day 6 and go with day 5.
Dr. Mamoun, I'm very sorry, but you have...
Since IVF field is a controversial field. I've seen this paper or this review. It was published on 2002 and in fertility and sterility, and they claim that day 6 blastocyst transfer increased the pregnancy, implantation, and live birth rates compared to day 5 blastocyst transfer in human IVF embryo transfer. And again, so what? Again, if I want to go back to the first slide that I said, different practice. So it depends on what you have studied, what you have learned, what you have gained through your experience, and what studies that you feel that this is what you want to work on and to follow. So at the end, very low number of embryos that will reach to day 7. Again, it was less than 8%, and they were fit for biopsy and freeze. And day 7 embryo might be higher in aneuploidy, that's correct. But still, the relationship between the aneuploidy and the slow progress or the embryo development it's still not clear. And still we have acceptable transfer for day 7, and the patient could, with a confident, transferring these embryos if they have no euploid embryo from day 5 or day 6. So if it was the last chance for you, just do it and freeze it. Day 7 blastocysts have not been reported to be candidate for fresh embryo transfer in any of the published studies. From here, I guess that's the end of the presentation. What is beyond day 7? Maybe next year we'll hear something new. We know that there are too many ethical issues and concerns about like culturing embryo beyond that day. Well, we still will learn maybe something new. Maybe you'll have some new data available by the next year. We know that with animals, I guess they have cultured embryos beyond that stage. And that's it for now. Thank you very much. I will show you just a few videos.
We don't have the time for videos. Sorry for that. Sorry for that.
So,
next time we will see your video. Sorry for that. We have an exam after our session. Sorry for that.
ممتاز. زي كنت أنا عم بتدرب على البرنامج.
معلش المرة دي أنا.
والله كنت سجلته. ما نكون ضيعنا وقت. الساعة صارت 1 بالليل.
مأمون, we don't have the time for the videos, please.
توقيت اللي على الشاشة هذا توقيت فانكوفر I think. طيب. زي ما انتم شايفين هون, as you can see, it's a 3BB embryo, I guess. And they want to do biopsy. So other embryos would say, no, would never do this. And they would wait, they would rather to wait till the embryo is expanded. However, you can see the biopsy is going very nice, away from the inner cell mass here, and took some cells and ready to go. Well, while other labs would say, no, they would rather to wait. And we can say, you're wrong or you're correct. Everyone has his own background, I would say. So again, where is the presentation? Here. Okay. All right. So. إيه مش فاهم. طيب دقيقة. البوينت تقريبا اختفت من عندي. Okay, try. Right. مش شايف الماوس, I guess. Anyway, I'll try to share the other videos and I will just explain what happened. So the other video is talking about a collapsing embryo before freezing. So it's a 6, so it's hatched, and you know it's very difficult to hold it with the stripper tips. So you just hit it with a laser, collapse the embryo, and then start your freezing. And you have to do it as well very fast because the embryo could go back and expand. So you just hit it and go for freezing. And the other video is about day 5, 6, 7, collapse, expand, repeat. Yeah. So this one was an embryo that being monitored under microscope, under embryoscope, and you can see the embryo going on expanding, collapsing, expanding, collapsing, expanding, collapsing. But it reached very nice, like 6 embryos. It was hatched. So those who are working with the embryoscope, they would say like this is a bad indication if the embryo was collapsed and it expanded a few times. And for those who want to do biopsy and they're not using the embryoscopes, it would be difficult to say, like, is this embryo good for biopsy or for freezing, because they would see it collapse. However, still, you can see check the zona. If it was thin, and then you see the embryo is very small and the zona is already expanded, so you would say already it's expanded. So yeah, you can just figure out saying it was expanded and collapsed. However, it might be a little bit tricky when you're doing the biopsy. So I think by this.
You have right, Dr. Midhat, you stop. You can present the next, yes. So we can.
Our next speaker is Professor Haider Musa. He's a member of our association, and he's an assistant professor in reproductive physiology and laboratory-assisted reproductive technique at Al Nahrain University High Institute of Infertility Diagnosis and ERT in Iraq. He is a lecturer, he's a trainer, and supervised many academic postgraduate courses. He has a PhD in clinical infertility reproduction, and he has a high diploma in clinical infertility and ERT and training fellowship in infertility and IVF. He is also a member of Iraqi Fertility Society, Clinical Embryology Medical Laboratory Committee. In addition, he worked as a lab are specialists and scientific consultant of many fertility IVF centers in Baghdad, Iraq. So welcome, Professor Haider from Iraq. You are going to speak about quality control, maintaining stability of assisted reproductive technologies laboratories. Please keep the time 15 minutes because we have an exam after our session. Thank you very much, Professor Haider. Marhaba. You can start sharing your presentation. Just you push on the green button and you have your presentation. Push the green button. اضغط على الدائرة الأخضر من الأسفل هيبان لك شاشة الكمبيوتر عندك. اضغط على البرزنتيشن تبعك. اضغط على الزر الأخضر. أيوه. Excellent. We want to hear your voice now. Unmute your audio.
Do you hear me, Professor Dr. Medhat?
ممتاز. مرحبا.
Thanks a lot, Professor Dr. Medhat, for this nice introduction. Thanks a lot to you and Dr. Xavier for moderating this nice session. Sorry, I was a problem in the internet due to the election day in Iraq at the beginning time. I think my voice is clear now and the presentation is clear to you?
Yes, clear.
Okay. All the mentioned topics by the previous speakers, all the topics of them can be lied within the quality control management, especially in the laboratories of assisted reproductive technologies. Relevance to my topic, no conflicts of interest to declare. Quality control is a vital part of quality assurance. All the laboratories can benefit from the quality control in terms of confidence and reproducibility of the test results. The recording process, the monitoring test variables such as temperature, chemicals, controls, equipment function, apparatuses, all the parameters also that mentioned previously by the speakers before since ours, allows one to look objectively and retrospectively at the parameters that are vital to the accuracy and precision of the test. So in addition to that, the documentation allows one to foresee a potential problem before the situation requires a corrective action and adversely affects the patient's results. So please don't forget, the quality in the laboratories is a mutual responsibility of the laboratories technicians or specialists and the clinicians. In addition to that, also the patients, the instructions that can be given to the patient, all of these make the quality control and lead to the best results and best outcome, which is the main aim of all the specialists in this field. So no matter how good the quality system is on a paper, the quality cannot be achieved if the theory cannot be translated into the practice. Quality costs, but all of us, let's remember, poor quality costs more. So the team should be from the logo or from the aim of together, everyone achieves more. This is the main aim of us in the reproductive medicine. There are 5 components which work together in a feedback loop, and this can illustrate how the continuous quality improvement is accomplished and the quality assurance is built into the laboratory process. For example, quality improvement, quality planning, quality laboratory processes, quality control, and the main thing is the quality assessment. All of these will be should be within our goals, objectives, and achieve the quality requirements. All of us, let's remember also the 5Q framework also defines how the quality is managed objectively with the scientific method, or what called PDCA cycle, PDCA cycle, plan, do, check, act, which is the main skeleton of the quality process, provides the planning step, quality laboratory process establishes standard processes, quality control, and the quality assurance, which is the most important than the quality control. All of these can provide measures for checks, and the quality of movements can provide a mechanism through which to act on these measures. So the quality management, as I said, is so important in the reproductive medicine, and assisted reproductive technologies laboratories. The quality should be competent, intensive, individualized care with personal involvement before the treatment, during the treatment process, and after the treatment. So quality management is needed to ensure the consistency, reproducibility of all methods, competence, and all the duties performed by the personnel. Today, every assisted reproductive technologies laboratory in European Union countries is obliged to implement a quality management system to establish and maintain a strict quality and quality assurance. Now I will go to take some tips. Many tips were covered, have been covered by the speakers. I will try to summarize all the general considerations of the quality control in the assisted reproductive technologies laboratories. So every laboratory should assess and should have the basic requirements, good quality apparatus, tools, and even the analysis, and even the instructions that can be given to the patients. For example, we can consider the history of the patient is the hub of the diagnosis, the patient of testicular biopsy, sometimes the quality of the sperm, which can need another sperm function test. For example, the DNA fragmentation index. Some oligoacino, especially the severe oligoacinoteratospermia, have they have a sperm, but not good quality. So we have to support all these analysis that can be within the basic requirements within the laboratory of assisted reproductive technology. The environment is so important. Some countries, especially in the Middle East, have extreme hot temperature, and so we need here an acclimatization and adaptability of the lab, heat ventilating, air conditioning, and many factors that are relevant to the environmental factors. The quality management, all of these the quality management should be in a parallel line to support the quality control and assure this. The quality of service. Also, as I said before, we need many tests to support and to make the best quality of good gametes that can be within the IGZI or within IUI and even the PGT later on. And so the optimization of the outcome, all of these should be maintained with the optimization of outcome. So all of us, as my previous speakers, we need to increase the take-home babies, and that's by increase the implantation rate and other relevant factors. So the main basic considerations in the IVF laboratories: allocate rooms and their functions, the evaluations of the temperatures, building materials, and also the furnitures, equipments. As I said, the heat ventilating air conditioning. So we need a special heat ventilating air condition to make the constant temperature particles, and the most important parameters here that I will focus about it is the VOX, volatile organic compounds issue, and other guidelines focus about this important parameters. In addition to that, the gas support, pure carbon dioxide mixing, and nitrogen oxide, especially also in the liquid nitrogen. UPS, many countries have a problem in the electricity. So also the UPS should be supported and should be within the basic considerations of the IVF or out laboratories. Transport or deliveries. This process is very important and should be within an easy access. So let's remember also when we need the PGT, and we have no genetic counseling in some centers, so we need to be supported by another lab. So also the quality assurance cycle should be done here in this lab. So let's remember a petition based about 10,000 good quality results but can be damaged by one poor quality result. So all of these should be within the quality control, quality assurance, and quality management, the personnel, competency, test evaluations, and all of these could be and should be within the quality management and safety customer service. Also, in addition to that, the seasonal variations, as I said before, about the VOX, volatile organic compounds, and testing quarter environment and the clinical pregnancy rate. Many studies covered this issue. and so important for. Let's remember the contamination can affect the outcome. The components from outside ambient air, laboratory circulated air, tissue culture, where equipment of gassing, heat ventilating specific organisms. So that's why we need certain filters in the laboratories of assisted reproductive technologies in general, and the special pattern of the XZ and vitrification and other lines. So the gas cylinders also, the contaminations here will be managed. And most important one, the personnel bioburden. This factor is so important also. And all of these leads us to the formation of VOX, which is the most harmful, which is the four not found anymore in the laboratories of assisted reproductive technologies. So volatile organic compounds vary in their polarity, molecular weight, and biochemical structure, and require different mechanisms for its removal. Must target all biochemical families, increase the effectiveness, and the most important line, the resonance, removal, and dual holding time in relevance to it. Here, a sample of the relevance of volatile organic compounds and the clinical pregnancy rate. Here we see the clinical pregnancy rate, how can be affected by the amount of the total volatile organic compounds. So here, the clinical pregnancy rate, we see here the maximum rate here and can be reversely correlated with the decreased amount of the total volatile organic compounds. So I think this can be a black box for assessment of many tests can be done with the laboratories of assisted reproductive technologies and see the outcome. This can be really the doorway or the black box of the failure sometimes, so it should be managed and should be monitored. So here, the development of the laboratory assisted reproductive technologies laboratories had been developed from the previous lines. In the past, here we see the small room, manual processes, and nowadays controlled environment. And I said many times, work management, clean room environment, and many lines can be relevant to the nowadays the COVID-19, PPE, and other lines. So many techniques also relevant to the 24 hours equipment surveillance network. For example, it can be the time lapse nowadays techniques, and all of these can be monitored. The main physical parameters, temperature, carbon dioxide, pH, humidity, gas, and particle count. All of these can be within the update lines or nowadays. I will focus about many very important point, which is called the key performance indicators. Every embryologist can have witnessing 6 movements per cycle at least. So here the laboratory key performance indicator, timely evaluations. For example, mature camelous oocyte complex at the over pickup day, mature oocyte after stripping, fertilization rate on the next day, for example, 19, 18 hours after XZ, and evaluation the normal fertilization rate, low or failed fertilization rate, also zygote cleavage rate, day 2 embryo development. So we see here many monitoring and many witnessing steps for the embryologist that should be taken in consideration. Day 3 embryo development, which should be assessed after 68 plus minus 1 hour. Good or better embryos on the day 3. So the main aim here, we should choose the main good and best selected embryos to transfer. Day 5 blastocyst development also, which here could be relevant to good implantation, and there will be 2 to 3 folds of implantation, which should be the blastocyst should be assessed after 116 hours plus minus 2 hours. Also, the embryo that's suitable for embryo transfer, vitrification later on, and also all of these should be monitored with the different data evaluation. Positive pregnancy tests, which maybe depend about positive beta HCG, implantation rate, which is depend on the number of gestational sacs in relevance to the peer transferred embryos, and the clinical pregnancy rate would depend about the fetal heart per embryo transferred. Also, all of these can be in parallel with the proactive actions, standard operating procedures, cleaning of premises. Premises here, I mean the buildings, equipments, dress code. The hygiene here should be taken in consideration. The behavior of the personnel also, preparation of dishes, selection of disposables, waste handling, all of these should be monitored with the standard operating procedures. And in addition to the most important point, the laboratory personnel protective equipment, PPE. And many studies said that safety is in a parallel line with the accuracy, with the quality. So also this could be managed within the quality control. The media products, disposables, here we have many terminologies, many glossary that's relevant to the quality control of these. So sometimes we should take in consideration the certain terms in the disposables and the media products that could be in the laboratory of assisted reproductive technologies, for example, FDA, Food Drug Administration, TGA, Therapeutic Good Administration, and quality tested with mouse embryo assay, sperm survival, endotoxins, luminous amoebocyte lysate. So many disposables had been tested in the mouse. So all of us, we should raise the hat to the experimental animals, especially the mouse and hamster. Egg collection also, the type of anesthesia.
Sorry for interruption, 1 minute is remaining.
The type of anesthesia, stimulation protocols, temperature control. Yes, I hear you, Professor. Okay, anesthesia, stimulation protocols, temperature control, pump pressure, all of these would be with calibration and services. Here, a big example of the interaction between the clinicians and the biologists. For example, if the biologists see this oocyte metaphase, and we see the smooth endoplasmic reticulum, this can be correlated with the high estradiol level. And also the large polar bodies here, if we see the fragmentation was opposite line, and this can be indicated for the aneuploidy. As I said before, the laminar flow should be within the quality control and should be good quality. Quality control of the micromanipulation. One of these applications is the IGZI. For example, here, anti-vibration table, the location, and the heating system within the micromanipulation. The quality control for the particles, I said before, the Vox, temperature, carbon dioxide, pH, and etc. The line of the culture media is so important. Yeah, for example, we choose a certain type of culture media within the cases of recurrent implantation failure cases. Another culture media, as my colleague said, sequential, one step accordingly to the history of the previous IVF failure or the age of the female, other factors. Vitrification also, the quality control should be within it. The toxicity of the components reduced by the speed of handling, short exposure to the vinyl vitrification solution, and the rapid warming. And in addition to the survival rates, developmental competency, and all of these lead to the selection of high quality gametes and embryos. All vitrification should be optimized.
An exam, please. 1 minute to resume, please.
Okay, I will try to summarize. Also, the ethics, the medical technical aspects, psychological ethical aspects, fulfillment of a quality expectation, all of these can be also within the quality control. Culture system, as I said before, the temperature, air quality, media composition, gas composition. For example, the media that include the heat should be within normal incubator or the incubator without CO2, and the media within sodium bicarbonate or any relevant buffer can be or should be within the CO2 incubator. And the culture system have been developed recently, and many global companies, all of these need to support the outcome of the results in the assisted reproductive technologies in general. Also, the quality control, quality assurance in the lab, so important and should be maintained. And all of us focus about the biophysical factors. There should be no fluctuation. For example, here the temperature plus minus 0.2 within maintained within this standard deviation, and also the concentration of hydrogen ions or pH based on the Henderson-Hasselbalch equation. So based on this equation, certain media can be designed for certain steps within the assisted phonetic technologies techniques. If here, for example, the effects of pH alteration lead to many toxic and alteration of pH. So this lead to, for example, disrupt the organization of mitochondria. One of the studies said that alteration of pH lead to the anomaly of the blastocyst development, and by the gene expression, embryo metabolism changes, differentiation, and redox stage of the cells. Last slides about the exit technical aspects. Here, for example, the trainer and the driver. So they'll have a KPI.
We have to stop, please. We have to stop. Please.
Okay.
We have an exam at 12, please.
Okay.
We have to somewhere have 20 seconds.
Okay. So also this the training of the embryologist and under the supervision, and these KPI should be also maintained. My take-home messages: the planning and scheduling of the equipment that should be calibrated, standardization, and all of this maintained also. So if you fail to plan, you are planning to fail, and there are no secrets to success. It is the results of preparation, hard work, learning from the failure. That was my take-home message. All of these lead to the mastering work workshop and work perfection. And I think the laboratory of assisted reproductive technology that never sleeps. Thank you so much.
Thank you.
Professor Haider, it's my pleasure to introduce Dr. Xavier Collet-Villard. Dr. Xavier is director of the Nataliance ART Center, Orléans, France, COFRAC technical auditor in ISO for ART and androgyny laboratories. His main interest is influence of environment on IVF outcomes, time lapse, and quality management. So, Dr. Xavier, you are going to speak about simplifying semen processing before ICSI. The stage is yours now.
Okay, I'm trying to, okay, perfect. I'm sharing my screen. Can you see it?
Yes, perfect. You can start.
Perfect. So I'm going to keep it short and simple before I know you get the exam after. So simplifying semen processing before ICSI. So we all know this scheme. This is the classical sperm preparation by density gradient centrifugation. This is the most used technique in the world in IVF centers, but it has drawbacks. The technical time is high, it's approximately 45 minutes. And there is always a treatment of multiple samples in parallel, and then there is a risk of mismatch that we all know and we all fear. And there are also multiple identity checkpoints that need to be double witnessed most of the time. So there is a cost in terms of time and also for stress for the embryologist. But there may also be an impact on the quality of the spermatozoa. This technique has been improved over the years by post-washing additional selection, just like Swim Up, Pixie, Max, HOS, birefringence, you name it. You have a lot of techniques that have been described with some different results. So what is the impact of density gradient centrifugation on the spermatozoa? There is a very recent and very nice study by Dr. Rad, who is in Lebanon, and he described that centrifugation, whether it is with density gradient or density gradient with swim up after density gradient or centrifugation before swim up, well, it can damage the spermatozoa. It elevates the level of ROS in the sperm that is generated by the spermatozoa. It also triggers a premature acrosome reaction, and there is also an elevation of the sperm DNA fragmentation. So if you don't do the centrifugation, you have very low level of centrifugation. This is here the simple swim up method here. So how can we simplify things from now, because we know that centrifugation may be detrimental to the spermatozoa? Well, there is a very nice RCT from an Italian team, which is quite recent, that shows that you can do an horizontal swim up directly in the ICSI dish. So you just have to put 50 microliter drops, 350 microliter drops of sperm media here. You put the sperm here. Can you see the arrow? Yes?
Yes.
Okay, so you put the sperm, the raw semen here, and you just let the motile spermatozoa migrate through the drops, and you harvest the spermatozoa here, and you inject, okay? Well, this RCT showed that when you did that, you had an improvement in cleavage rate and blastocyst rates. Implantation rates were not improved, nor clinical pregnancy rates. And this technique has been also used by another group, the group from Fatimi and Barry, and they use quite the same technique with one drop where they put the semen and one drop where they harvest the sperm. So, but they described an interesting phenomenon that takes place when you do that. There is a fluid movement from the drop without raw semen to the drop with raw semen. And so, and there is also, so the motile spermatozoa have to go against the flow. And this phenomenon is known as rheotaxis, okay? And then they used the spermatozoa that were able to go against the flow, getting out of the raw semen, go against the flow. And they use it for ICSI, and they showed that they have more high quality embryos, just like the Italian team, but they also showed that they had more implantation rate and clinical pregnancy rate. But I insist for you to look at the results they have. First of all, there are not many patients. This is the drawback of many studies on the subject. And it's quite like they have a magical control group here. Implantation rates are very low in the group 2, okay, the one with conventional method, and quite high when you look at the group 1, the one with rheotaxis selection, okay? So what we can say from this study is that it improves it can improve the embryo quality and maybe sometimes the clinical pregnancy rate, the clinical outcomes. So what can we do to avoid centrifugation? We could also use what nature put there for us to use. Okay, for example, we could use the cumulus or the cervical mucus for sperm selection. And we can do it in an ICSI dish. So the first study that I want to present was a study about using cervical mucus. It was only a descriptive study that showed that the spermatozoa that are able to pass through cervical mucus are better condensed and, most importantly, have practically no DNA fragmentation. You can see it here. It's nick translation. It's the equivalent of tunnel. But there are drawbacks by using cervical mucus that I will present after. Another study focused on the quality of spermatozoa that would be filtered through cumulus complex chunks, okay? So basically you put the raw semen here or treated semen here, you put the chunks of cumulus complexes here, and the spermatozoa that will pass through will be harvested here, okay? And in the control group, you don't have any cumulus, so it's only motility. And you can see that there is an improvement in motility parameter, especially velocity and ALH, but also in the normal form and the DNA fragmentation incidence in the spermatozoa. So it seems that going through the cumulus complex is improving spermatozoa quality. But what about clinical results? Well, I will present the dish after. So there is this study from 2018 from a Chinese group that showed that when they did that, when they used the COC selected spermatozoa for ICSI, they had a better utilization rate for oocyte, better embryo quality, but they didn't notice any improvement in the clinical pregnancy rate or cumulative pregnancy rates. I mean, no significant improvement, but if you look at the numbers, you see that there is a tendency to clinical improvement, okay? Here is the dish that I use in my lab. This is quite a mix between the techniques I presented. The raw semen is put it here in a sperm medium drop, okay? I do another sperm medium drop here without semen, of course, and a bridge between these two drops. And I put the cumulus complex just right here. So the spermatozoa have to pass through have to pass through the cumulus, and then I harvest the spermatozoa that have been selected here and use it for ICSI. It's directly, without centrifugation, it's direct selection in the culture dish. So what are the drawbacks of using female Spartner material? Well, first of all, the quality is variable because every patient is not the same. So the mucus could not be good. The cumulus sometimes are quite awful. You can see that when you harvest the cumulus during your PU. So there is a lack of reproducibility. And there is also, especially for cervical mucus, a potential infectious risk and also a risk of contamination. Well, when you use the cervical mucus, you don't know what happened with the woman 7 days before. And you know that spermatozoa can survive in the cervical mucus, in the genital tracts a long time. So I wouldn't advise using cervical mucus, but it's not the same for cumulus because, I mean, cumulus, we use it every time. We use cumulus selection every time in classical IVF. So I don't think there is a risk at using cumulus in an IVF setting. But there is a risk of partial selection because the spermatozoa could just go on the walls of the media and not go through the cumulus. Well, the last drawback is it is adding supplementary steps. For example, if you want to use cumulus selection, you have to trim your oocyte. You have to trim your oocyte before using it. Noureddin, we can hear you. But I mean, if you do it in your lab every day, the trimming, this is not a supplementary step that is difficult to overcome. So very shortly, because we don't have time, I want to take a glimpse at new microfluidic devices. So, you know, the promise of microfluidic is that without centrifugation and using flow, for example, and channels, you can select viable sperm, viable motile sperm, and use it for ICSI or IVF. What I wanted to present you is this new study about a rheotaxis-based sperm separation, which uses a biomimicry microfluidic device. It's a really new study. It's been published, I think, 1 month ago. And this is very interesting. This is a microfluidic device. So there is an active flow, okay? And the spermatozoa, the raw semen is put here, and then the spermatozoa will migrate, motile or dead. They will migrate in the flow. But the really good spermatozoa, the motile one, at some places in the microfluidic chips where the flow is has less velocity, they will orient against the flow, and with the motility will be concentrated in small cavities, just right here. So if you have no flow, all the spermatozoa are going there. If you add the flow, there will be a selection zone, which they call the rheotaxis zone here, where the spermatozoa will orient against the flow, and the most motile one would be able to concentrate in the cavities. And you can see here the tracks of the motile spermatozoa that are going against the flow and then pushing in the cavity. So rheotaxis is implicated in really a lot of sperm selection technique that use flow or that use the motility of spermatozoa as a prime selection method. So there is another microfluidic, I don't know if you can say microfluidic, but let's say it, a microfluidic technique that is called the Zymote or the Fertile Ultimate or Fertile Plus, depending on the countries. And it can use channels where the spermatozoa can migrate. It's only migration. And when you look at the results that have been displayed in RCTs, well, you get, just like we found already, a better quality of the embryos. But the clinical outcomes are not always good and not always better than the classical selections. I want to present the other microfluidic device that is sold as the Zymote selection method. This time, it's a selection chamber that is made of a small cavity here, and there is a filter which is a polycarbonate porous membrane where the size of the pores are controlled, okay? And the spermatozoa can go through these pores to an IVF media, just right here. And they claim that in 30 minutes, you can harvest a very good quality spermatozoa without DNA fragmentation and with low rates of Ross generation. But we have not a lot of RCTs for this particular device. So I would advise caution for the moment. And I would advise caution because the material that is used is polycarbonate. And polycarbonate is well known to be bisphenol A. So it's an endocrine disruptor, bisphenol A producer. So we need to be cautious and we need better RCT to validate this method. So I want now to discuss these small number of studies. First of all, I want to say that there is a lack of consensus regarding a gold standard for sperm selection. But what we can say from all the studies that have been made till now is that avoiding centrifugation improves spermatozoa quality, just like DNA condensation, DNA fragmentation, morphology, motility, Ross generation, mitochondrial membrane potential. And sometimes it can improve clinical outcomes, not always. But what is certain is that avoiding centrifugation reduces the burden of sperm selection and also the associated risk, mismatch, for example. So it's very cost effective if the device is not too expensive. And the main thing is that it's a dramatic improvement of workflow in the lab.
Please, 1 minute.
It's the last slide. So I told you 10 minutes. So apparently better quality spermatozoa doesn't necessarily mean that you will have better clinical outcome. However, we can say that there is a possible impact of conceptus health. So we need large sibling studies with oocyte sibling studies comparing these different techniques. And we need also a long-term follow-up of the children that have been conceived through this technique. So I put the last ICANN publication. Where can we stand to protect the conceptus from DNA damage? Well, by using better isolation of sperm with low levels of DNA damage. And I think that these techniques could provide a means for us to get the best of what the man can offer us at the day of the OPU. And that's it. Thank you.
Thank you very much, Dr. Zabi Villar, for this very interesting presentation. Professor Monsef Ben Khalifa, it's a great pleasure to introduce you. You are my old and very dear friend since 30 years. And Dr. Monsef Ben Khalifa obtained his PhD in 1992 in Clermont-Ferrand University, and he's qualified in reproductive biology and medical cytogenetics from the School of Medicine. He's involved in ERT genetics practice for more than 15 years on collaboration with Professor Yves Menezou. He is directing ATL Research and Development, Reproductive Biology and Genetics Laboratory since 1998, and co-directing Global Genetics Laboratory Cervix Network since 2003. Dr. Ben Khalifa is collaborating and consulting different groups involved in ERT and genetics in Europe and Middle East in North Africa. He was appointed as scientific consultant in 2007 as a consultant of reproductive medicine and genetics in Laboratoire des Lois, Paris. Dr. Ben Khalifa is author and co-author of more than 17 national and international publications with the main interest for research and development in embryology and genetics. So the stage is yours, Dr. Monsef, to present sperm analysis. Are we doing well? Nice question.
Okay. Thank you very much, mon cher ami. Hop, il faut que je trouve ma présentation.
Yes.
Hop. Et Okay. Okay. Okay for you now?
We don't see the presentation.
You don't see the presentation?
Yes, we only see you. So you have to go to share screen.
Yes.
And select your presentation, and we'll see it.
Okay. That's fine.
I think it's fine. I will tell you in a few seconds. Yes.
Okay. Okay. Thank you very much for the organizer for this kind of invitation. And Medhat, c'est toujours un plaisir de t'avoir au téléphone ou physiquement. Alors, the question is, if in 2021 we are still doing well for the sperm analysis based in the complication of the indication. Not move the slides. Okay. If we go to the 6th edition of the IIHU, there is a basic examination of sperm analysis, and all aspects of ejaculated collection and examination must be assessed using proper standardized procedure if the results are to provide reliable information. And from this recommendation, we will face the quality assessment, the quality control, and the quality management in our daily andrology laboratories. But usually what's done in 80% of andrology lab, we are doing a classical semen analysis. And this is a basic evaluation of spermatogenesis and spermiogenesis. And this is extremely basic analysis. What I can say, it's descriptive analysis. That means we are looking for the volume, for the aspect, for the enumeration, the vitality, using only the basic observation on the microscope. But this basic analysis and this basic interpretation is also related to the population distribution of characteristic, and therefore prone to misinterpretation at the individual level. And I believe that today, in 2021, it's extremely conservative to investigate the fertility potential of one man consulting for infertility based only on this descriptive analysis, because we can miss a lot of information based in the diagnosis of specific lesion, what will be the indication of dysfunctional and or functional potential, and require an understanding of the relevance of sperm pathophysiology. What I can say that the classical sperm analysis today are not exploring all factors involved for successful fertilization, oocyte activation, and embryo development. And based on the recommendation of the IIHU 16th edition, I think it's important to gain a deeper insight into the biological basis of male factor infertility. A battery of functional tests has been developed aimed to assess the competence and the maturation of a human spermatozoa to fulfill the fundamental process essential to conception. We as a groups, international network, we said, thanks to the molecular andrology tools, now we have a new battery of tests that we can offer for sperm genome decay analysis. That's what we say, the genomics, like the aneuploidy, the DNA fragmentation, and the chromatin integrity. But also now we develop basic techniques to analyze the methylation profiles, the PLC zeta, and the dosage of the free circulating DNA as an indicators of oxidative stress. And I will show you some data from that. That's clear if you go to do the fish analysis in the sperm, if you are suspecting any defect of the meiosis on the sperm. This is very easy techniques that you can assess at least 10 or 12 chromosomes. This is an example of XY and 18. And this is a very old work done in Antoine Béclair hospitals when I was there. And you can see there is a clear relation between the clinical outcome when you use one sperm aneuploid with an abnormal chromosome segregation. That means you will lose the chance of pregnancy per transfer. You will increase the implantation, you will reduce the implantation rate, and you will increase the abortion. And this is very important to investigate how the aneuploidy are in the sperm. Now, there is a clear debate about the sperm DNA fragmentation, and what will shown that's for all men eligible for IUI. What's the literature report? That's at least 20% of normal sperm eligible for IUI. They have more than 30% of DNA fragmentation, and this is important. And this is reported also in 2011. That's when you use sperm in IUI with more than 25%, you will reduce in significant percentage the chance of pregnancy after IUI. Also, if you can see what will be the impact of the DNA integrity in clinical outcome, and you can see that's more than 30% of DNA fragmentation, you can use it as an indicator to predict the clinical outcome. And you can see even for the embryo quality or for the implantation rate. And it's clearly shown that's when the sperm DNA is highly fragmented, you will impact the chance of ICSI. This is also a different data coming from the literature and mainly from one of our groups with the Dr. Winsley groups. That we show the impact of paternal age on genome decay and the clinical outcome. And you can see that's when the sperm is fragmented, you will increase the risk of embryo blocking, you will reduce the fertilization rate, you will reduce the percentage of cleavage rate and the blastulation rate. And at the end, you will impact the clinical pregnancy and you will increase the miscarriage rate. We want more than the DNA fragmentation, and we want to make the correlation between the sperm DNA methylation on relation with the sperm DNA fragmentation and chromatin integrity. And you can see there is a clear relation between the epigenetics profile of the spermatozoa and the chance to fragment the DNA or to increase the chromatin decondensation. Finally, this is the PhD work of D.B. Mongeon. Now she is a senior embryologist. She was my PhD. And you can see clearly the correlation between the methylation profile. That's when we are talking about the epigenetics disorders, how it will impact the sperm parameters, especially the count and the motility. And there is now, we should talk about the impact of epigenetics disorders on sperm parameters. This is also a clear demonstration of the impact when you investigate the sperm DNA methylation with the morphology of the sperm. And this publication was done with Guy Cassouto when we make the correlation between the different score of the sperm and the methylation level. And in my opinion, this is the first publication came in the literature showing the clear indication of MC and the morphology of the spermatozoa. When the sperm is a score 6, that's mean very bad morphology of the sperm. We demonstrated clearly that there is a high methylation levels. Now, this is our last paper showing that now we can go to the molecular andrology and make the correlation between the impact of oxidative stress and mitochondrial dysfunction on sperm quality. And this is clearly demonstrated when we went and we make the quantitative PCR free circulating DNA in the sperm plasma. And you can see here that's a clear correlation between the level of free circulating DNA in the plasma when you compare the patient versus the control. And also you can see in the level of free circulating DNA in azoospermic man versus the control and the teratospermia versus the control. This is why we believe in the future, the investigation of the impact of oxidative stress and mitochondrial dysfunction on free circulating DNA in peripheral blood or seminal plasma, and how to regulate this physiological dysregulation via specific treatment, such as DNase treatment or antioxidant. That's clear now. I think the future of andrology and the sperm lab is not a descriptive techniques, but it's mainly molecular technology to improve the potential of male fertility. And the end, you can see when we make the study, this is the thesis of Elodie Lefranc. She's now medical biologist in my department. When we make the correlation between the capacity of the sperm to correct his own oxidative stress and the sperm parameters, and when the SORP is elevated, that means now we can really introduce an algorithm, because if the SORP is abnormal, you see clearly a correlation between the morphology or the mobility and the numeration of the sperm. That's clear now. We have a lot of information to put an algorithm which test we can start to investigate the genome and the epigenome disorder of the spermatozoa. And you can see here in normal patient with normal sperm oxidation reduction potential, you can see that the normal parameters after you go to the teratospermia, the astenospermia, and the oligospermia. But if you have an increase of the SORP, you really imbalance the diagram. And this is very important for the future patient investigation. Finally, this is the last test put in our department. This is the PLC zeta. When we talk about the normosperm infertile, that means you will do ICSI, you will do IVF or IUI. And when we measure clearly the level of PLC zeta, we develop this test with really sandwich techniques. You can see that for the man selected for sperm donation, the level of PLC zeta is higher than the patient coming for IVF in our department, and also higher than the ICSI patient. That's clear, in my opinion, for sperm with multiple ICSI failures. I think we should go and see the level of PLC zeta, and from this we can advise to the doctors to propose to the patient the calcium immunophore protocols parallel to the ICSI, and from that our preliminary data confirming the benefit of this in our daily practice. In conclusion, I think it's time to change our approach of sperm investigation by adding genome, epigenome, and mitochondria dysfunction analysis, because inherited or de novo genetics and or epigenetics disorders and energetic imbalance can produce problems of oocytes activation and embryo development, implantation failure and miscarriage, risk of imprinting disease at postnatals during the prepubertal and adult stage. And I think we as a scientist, as an embryologist, it's time to revisit our practice and services to support the clinician and patient for better clinical therapy and management in repeated ICSI failures, or when we are suspecting severe male factors impacting the clinical outcome in IVF. And finally, I would like to thank my team with I'm collaborating. Thank you very much.
Thank you, Monsieur.
Thank you, Monsieur, very, very much for this excellent review. I would like to thank all the presenters today for the excellent presentation. And I would like to thank also the Association for Scientific Research of IRIFIV-AISRG for hosting this very interesting meeting. And I think we are short of time now.
Yes, we are asked by the committee to start the exam now.
Yes, and unfortunately, speakers extended beyond their limit, and we were not able to stop them. So, hoping you are gathering us in another meeting to discuss all this.
Yes, exactly. We share some group. I think I organize something like that for a forum, question-response forum via YouTube.
Sure.
It will be published in YouTube. All this webinar. Thank you a lot, Dr. Medhat. You are for your availability, for your kindness.
It was my pleasure.
Thank you, beaucoup. Thank you. And I do equally thanks all the teams, all the speakers, all the attendees. And I let my president, Dr. Zarqawi, say 2 words before the exam, please.
Que tous ceux qui m'entendent sont francophones, merci beaucoup d'être là. Ça fait plaisir de voir. On va, rien qu'avec ce que vous avez dit, on va changer beaucoup de choses dans notre quotidien et dans notre travail, que ce soit en matière de spermiologie, en matière de biologie et en matière de transfert et de préparation. Dans l'ensemble, on avance énormément et ça fait vraiment plaisir de voir que le train avance et on essaie de s'accrocher. Thank you very much for all.
Merci, merci. C'est une excellente expérience, très réussie. Dieu merci, grâce à la qualité de nos invités, que je remercie aussi. Et je vous dis à très, très, très bientôt. On va rester en contact à tout le monde, Dr Haïdar, Dr Nater, tout ce que je vois, professeur Ahmed.
À bientôt.
Shukran, shukran. Barakallahu
À
fikum.
très bientôt. Merci beaucoup.
Bientôt.
Merci.
Merci.
À bientôt.